Good evening. We'll call the meeting to order, and if you'll join me for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Dee, if you could call the roll, please.
Director Nicholson.
Present.
Director Stewart.
Present.
Director Wallace.
Present.
Director Danielson. Director Eapen.
Thank you. Well, it comes time every December for election of officers, and that time has come around again. So at this point, I would entertain a motion for election of officers of the board.
Mr. President, I have a motion to make. First of all, though, I'd like to thank you for your service this last year. I think you've done a good job in a lot of difficult areas.
Thank you.
And thank you for what you did.
Thank you.
But it is time to propose a new board, a group of new board officers. And I would like to make the motion that the president of the board of directors be Michael J. Wallace. The first vice president would be Bernard L. Stewart. The second vice president would be Jacob Eapen. The treasurer would be Patricia Danielson. It's good she's not here to hear me make that mistake. And the secretary would be William F. Nicholson.
Thank you. We have a motion. Do we have a second?
Second.
Second. Dee, could you call the roll?
Director Wallace.
Aye.
Director Stewart.
Aye.
Director Danielson. Director Eapen. Director Nicholson.
Aye. Well, congratulations, Mr. President.
Thank you very much.
We'll swap seats.
What do we have to just?
If you want, I'll give you the gavel,
Yeah,
and we
just-
can
yeah,
do it from there.
That's
Okay.
easier. That's easier.
Point the camera in his direction.
Well, I want to echo what Director Stewart has said. Thank you for your service. You've done a great job during this last year,
Thank you very much, Mike.
and I'm sure we'll be called on you again.
All right, thank you.
Yeah. Okay, Nancy, please.
Have we looked at the minutes? Oh, no, we have an education session, I'm sorry.
Yeah.
I am getting a little behind myself. Before I turn the microphone over to our speakers, I wanted to let our audience know and the board that we did have our Joint Commission survey of our stroke program on November 28th. It is a one-day recertification survey. It was truly a great success. We have much to be proud of in our stroke program. They found one minor finding. It bears repeating. I'm very proud of all the people that were involved in our survey. Our clinicians showed the surveyors how great our stroke program truly is. Denise Lynch and Dr. Rose delivered the presentation that you're about to have as your education session, and this was what was presented to our Joint Commission surveyors. They did a wonderful job highlighting the many strengths of our stroke program and featured our collaborative team approach. With that, I'd like to make introductions of our two speakers tonight. I'll do it consecutively, and then they can do their speaking. Dr. Rose joined the Washington Township Medical Foundation in early 2014. He received his undergraduate degree from Stanford University and his medical degree from Columbia University's College of Physicians and Surgeons. He received his medical and neurological training at New York Presbyterian Hospital's Neurological Institute, where he was selected as chief resident. He did a 2-year neurocritical care fellowship at the University of California in San Francisco. He is an expert in neurointensive care and cerebral vascular disease, and was among the first 100 physicians in the world to become certified in neurocritical care. He's also board certified in neurology as well as vascular neurology. His experience and leadership augments our comprehensive stroke and neurosurgical programs, especially in cerebral vascular neurosurgery and interventional neuroradiology. He personally provides patients treated at Washington Hospital with a continuity of care that is crucial when treating the full range of cerebral vascular conditions. He is our co-medical director of the stroke program, along with Dr. Kalsa. Also speaking tonight to the board is Denise Lynch, RN. She's worked at Washington Hospital for over 21 years as a critical care nurse and a stroke nurse. In the past year, she was promoted as stroke coordinator and is responsible for the stroke program development at our hospital. She earned a Bachelor of Science in Nursing degree from San Jose State University in 1993, and then completed a Master's of Healthcare Administration in 2016 from Cal State East Bay. She has a neurovascular and neuroscience nursing certifications. She enjoys leading community outreach efforts and educating staff to promote evidence-based practices in caring for stroke patients. And with that, I'll turn the program over to our presenters.
Well, thank you very much, Nancy, for that very kind and detailed introduction. I'm glad you didn't throw in my social security number in there as well. And also thank you to the board for having us come present our presentation that we gave to the Joint Commission a few weeks ago. We truly are very proud of our stroke program here, and we're happy to be able to provide you the sort of an update about our stroke program, our strengths, our achievements, and also some changes that we've had in our program lately. So I'm going to start by giving you an overview, and then Denise will pick up with some of our performance improvement projects that we've been working hard on, a little bit of our outcomes, and then I'm going to end with some information about our outreach and community education. So this is not news to many of you in the room here, but in case people are watching from the community and don't know that much about our hospital, again, Washington Hospital is a community acute care hospital licensed for nearly 360 beds. We're one of the only 7% hospitals in the nation that is magnet recognized. This is a testament to our outstanding nursing care. We are the district hospital for Washington Township and offer quality services for members of Southern Alameda County and beyond. And we're overseen by an elected board of directors who sit in front of me right now. We are a high volume center, so if you look at CMS, we're considered a high volume emergency department. In 2016, we had over 53,000 visits in that calendar year, which is second highest in Alameda County, only second to the hospital that has the trauma center. And patients that have stroke that get care in our hospital are found in typically one of these 4 units. In our emergency department, where often the care begins, the sickest patients spend some time in our critical care units, where I spend most of my time, the ICU or our CCU, but we also have a 6 West medical surgical floor with dedicated nurses that have extra training and expertise in stroke care, and we also have a newly opened observation unit in 3 North for our patients that are admitted for or brought in for a high-risk observation and not necessarily admitted. And in terms of the hospital mission and values, these are very important to the core of our hospital. Our mission is to meet the healthcare needs of the district residents with not just medical services, but education and research. And we have a very strong patient-first ethic here, putting the patient and their family at the center of all healthcare decisions and care. And we strive to provide very, very high quality, yet affordable and convenient care with a personal attention. And specifically our stroke program mission is to improve the care of our stroke patients in the community, and anybody that comes into our hospital for that matter, even if they come from lands far away, focusing on patient and community education, having a systematic process to treat acute and recovering stroke patients, which we use national accepted clinical guidelines. We also want to be involved in developing advanced treatment modalities based on the latest scientific data and knowledge. And we also have a goal to participate in research in stroke and neuroscience. This is a slide that demonstrates some of the background of what our stroke patient population looks like. If you look up here, this graph just highlights the breakdown of the ages of our stroke patients. And the blue are the the Washington hospital averages, and the red are the nationwide numbers. So if you notice by age, it's broken down into 4 age brackets here, and we're actually very similar to the nation in terms of our typical ages of stroke patients, except in the patients that are older, age 85, we have a slightly higher percentage of patients that are in that over 85 age range. In terms of men and women, we're very similar nationwide versus Washington Hospital, fairly close men versus women. If you look down below here, distribution of race or ethnicity, we have a significantly decreased percentage of patients that identify as white, and a decreased percentage that identify as black, but a significantly higher percentage of patients that identify as Asian heritage, over 13-fold, for example, and slightly higher for people identifying themselves as other. We also have a slightly higher representation of patients that identify with Hispanic ethnicity compared to the national average. How about the risk factors? What risk factors do our stroke patients have here at Washington? How do they compare with across the nation? Well, the 2 biggest ones are very similar to the rest of the country: diabetes and hypertension. Hypertension being the most prevalent stroke risk factor, 70% nationwide and here at Washington Hospital. I do want to draw your attention to a couple other things, and this may be related to the fact that we live in California, but you notice that we have a much lower incidence of smoking, much lower incidence of obesity, and slightly lower incidence of hyperlipidemia or high cholesterol compared to the national average. And so those are in our favor, but doesn't mean that we have to ignore those risk factors, of course. How about what's our stroke patient volume here in Washington? Well, ever since we got certified as a primary stroke center in 2007, our numbers have increased from where the numbers used to be in the mid 200s a year to in the 4 to even 500s number of stroke patients admitted to the hospital per year. And since that time, about 10 years ago, the numbers have been fairly stable in the high 400s range with slight ups and downs over time. And in terms of what kind of strokes patients are having when they are admitted to our hospital, that's this bar graph down here. 60% of our patients with stroke have a typical stroke, a blocked artery stroke, so they have an injury to their brain from a blockage of an artery. 25% of the patients will have a warning sign of a stroke. We call that a TIA, a transient ischemic attack. It's a warning sign of a stroke, but there's no permanent damage to the brain. 6% are patients that have what's called a subarachnoid hemorrhage. It's bleeding into the fluid spaces in the head, most often from a ruptured brain aneurysm, and we have particular expertise and interest in treating this disorder at Washington Hospital. And 10% are patients that have an intracerebral hemorrhage, or ICH, that's bleeding into the brain tissue itself. So a little bit more about our program. We have a very supportive reporting structure with our key stroke team nurses down here that report to Denise, our stroke team coordinator, and there is a senior director of nursing, Katie Choi, who works very closely with them and with us, and above them are Stephanie Williams and Nancy Farber and the board of directors, who provide outstanding administrative support and guidance. We have not just 3 stroke nurses to boast about, but these are the core stroke nurses, in addition to Denise, that are vital members of our team, Melissa, Tasha, and Charlene, but we have several other stroke nurses that provide 24 hour a day, 7 days a week care for our stroke patients in the hospital. It's one of the few places in the world that has that capability. And just this past year, myself and Dr. Prajit Khalsa have assumed the role of co-medical directors of the stroke program. In terms of our inpatient services, again, we put the patient right in the center, patient first ethic, and there are a big team of people that are involved in the care of stroke patients here at Washington, including neurologists such as myself, stroke nurses, we have case managers, social services, rehab therapists from physical therapy, occupational therapy, speech therapy, swallowing, and of course our outstanding nurses in any part of the hospital. We also have the ability to provide spiritual care, consultation, and support, as well as palliative care service, which we occasionally require their help. Our stroke nurses do daily multidisciplinary rounds on our stroke patients to follow them very closely to make sure that their care is going in the right direction and we're picking up any changes in a timely fashion and making sure that we're doing everything we need to do, not just to comply with the Joint Commission requirements, but to really get the most optimal outcome for every single one of our patients. And they do a great job communicating these issues amongst themselves and with the other healthcare team members. And these multidisciplinary team members include, of course, the bedside nurse, the charge nurse, representatives from all the rehabilitation services, and case management. We also have a very strong team of critical care intensivists that man our CCU and ICU 24/7, and two of the intensivists, one being me, are board certified in neurocritical care. And the general medical intensivists are well educated in the latest in stroke treatments and protocols. And we have ongoing education we provide for them. We also have emergency department rounds with the stroke nurse on a daily, if not multi-times a day basis. We have very advanced neuroradiology capabilities here at Washington Hospital, as well as neurosurgical services, which aren't necessarily highlighted on this slide. We have capabilities to provide the most modern and advanced imaging techniques, such as CT angiography, which is putting dye in the patient's veins and highlighting all the blood vessels in their head and neck. We can do a special test called a CT perfusion scan, which doesn't just look at the brain tissue or the blood vessels, but how well the brain is getting blood flow to various parts of the brain in health and in various stages of injury, especially related to stroke. We have an MRI scanner. We can do MRI angiogram scanning, as well as we can do lots of ultrasound tests of the carotid arteries and even the intracranial brain arteries. We can do ultrasound studies as well. We have very strong interventional neuroradiology capabilities here with Dr. Thomas and some of the other interventionalists. We can do carotid stenting. We can take out clots for acute stroke treatments. That's this cartoon that's highlighting a device that's put into a blocked artery and where a stent is put through the clot to then extract the clot to help improve the outcome for a severely affected stroke patient. We can balloon open up narrowing arteries after subarachnoid hemorrhage with angioplasty if we need to. We can treat aneurysms from inside the blood vessel or outside the blood vessel with either the latest of micro endovascular techniques or open neurosurgical techniques. And our procedural volume is going up in terms of what types of acute stroke therapies that we're able to do. We also have a very strong group of neurosurgeons that can respond at a very quick time frame for our very, very sick patients and provide acute neurosurgical care with catheters into the ventricles or to do even a skull decompressive surgery to save a stroke patient's life as needed. I already highlighted this. We have a very unique and outstanding stroke nurse program here who are a core component to why we can provide such excellent care to our stroke patients. But the stroke nurses are not only involved in the acute stroke patients' care in the emergency department or in the rest of the hospital. They also function as a rapid response team member. They coordinate interdisciplinary care issues, help coordinate discharge planning to get patients out in a timely and appropriate fashion. They do a lot of time, especially Denise, to collect data, disseminate our data, and to work on performance improvement projects, to work with the Joint Commission to make sure we get recertified on a bi-yearly basis. They also provide a huge amount of patient and family education to support our bedside nurses who also do an outstanding job at doing that. And they're involved in hospital staff education as well as community education. Other ways that we disseminate data and guide the progress of our program, we have a stroke review committee that meets monthly with multiple representatives from the different departments, as well as we have an annual quality steering committee presentation, and we do an annual meeting to the board of directors like we're doing just now. And now I'm going to turn it over to Denise to talk about some of the performance improvement and outcome measures.
Thank you, Dr. Rose. Okay, so our first performance improvement plan is Target Stroke. And what that is looking at door to TPA times in less than 60 minutes. And we need to meet this measure in 75% of our stroke patients. And you can see from 2009 that we've had steady increase. We've improved our times quite a bit. The next performance improvement is looking at IV TPA to door to drug in 45 minutes, and we need to look at that in 50. We need to be able to accomplish that in 50% of our patients. And again, you can see from 2009 to currently, we are well achieving that. And a few reasons for that is because we stopped rooming the stroke patient when they came through in the emergency room. So we stopped rooming them, and then also what we've done is we started giving TPA in the CT scanner. So that's really improved our times. Our median time currently for 2017 is 32 minutes, and our best time from door to drug is 14 minutes this year. So our next performance improvement is Code Neuro. So Code Neuro was initiated back in July of 2016. And what that is, it's an overhead page to everybody in the hospital and alerts everybody that there's a stroke patient coming in either via EMS or a walk-in. And so the criteria for being able to call that Code Neuro is symptom onset less than 6 hours and a positive FAST scale. So again, the overhead page goes out to everybody, Code Neuro, everybody comes in to see that patient very quickly, which includes this team of the ER physician, the ED staff, the stroke nurse, phlebotomist, pharmacist, lab, everybody comes together to quickly assess the patient with the goal of getting the patient to the CT scanner in 45 minutes and ultimately getting TPA into them very quickly. So what we did is we decided that we would look at, does Code Neuro really work? So we looked at our data, and in fact, it showed that we were significantly faster both in CT, getting the patient to CT and the CT being read in 45 minutes, getting our labs back in 45 minutes, and getting the physician to the patient's bedside in 15 minutes. So you can see in these graphs here, the green line being the Code Neuro, that's when the Code Neuro was called. So, and then in comparison, the red is when we did not call the Code Neuro. So you can see that each one of those metrics was met when we called the Code Neuro. And incidentally, the last graph, the labs got better sort of on their own and for various reasons. The beaker system, the signal tracking board in the emergency room, and also there was a lot of education that lab did with their phlebotomist. Okay, so the next performance improvement that we look at is CT turnaround. So CT within 45 minutes. And you can see over 2017, we've done very well. We've gone over 80%. We had a small dip there and we came right back up. Another performance improvement is IV TPA. So after we give IV TPA in the emergency room, the patient needs to have their vital signs and neuro checks for the next 24 hours. So this measure we've done very well in. You can see we did 100%, we dropped a little bit, we did some education with the staff, and we came right back up. This slide is looking at, again, just our target stroke. So again, IV TPA is 60 minutes. It has to be met in 75% of the stroke patients. IV TPA in 45 minutes needs to be met in 50% of the patients. So you can see we meet that measure. The third graph here at the bottom there is our newest PI plan, and that's the Neuro IR. So we found that we needed to improve with our Neuro IR checks. And what that means is those patients that have had a thrombectomy, or they've had a coiling, or they've had a stent, they need to have 4 hours of monitoring their neuro checks, groin, pulses, vital signs, etc. So we put different plans in place and we failed, and we tested again. We put other plans in place, and lo and behold, this quarter we are 5 for 5, 100%. So we're doing very well there. Another performance improvement plan that we are doing is we monitor door to groin. So what that is when a patient comes in with a stroke, and maybe they've been given TPA, or maybe they've been ineligible for TPA because they're outside of that 4.5 hour window. We still want, and they're eligible for an IR, interventional radiology procedure. So what we do is we monitor the time from the time they come in, excuse me, to the time that groin puncture. And our internal goal is 120 minutes. Currently, we're at 209 minutes. So this is an area for us to improve upon in the coming year. Okay, so now for some outcomes. So the stroke program has 8 to 10 core stroke core measures, such as stroke education, aspirin by day 2, VTE by day 2. And you can see the stroke program is doing very well. We are over 85%. And this is just looking at patients with atrial fibrillation treated with anticoagulant, and over the years we've achieved that measure. This is looking at patient outcomes. So this is stroke mortality ratio. So basically the red line is other California hospitals. We benchmarked ourselves against other California hospitals, and Washington Hospital has a much lower stroke mortality risk ratio in the acute ischemic stroke population. The next slide here is where we took a look at acute ischemic strokes and hemorrhagic strokes combined, and again benchmarked ourselves against other California hospitals. And again, Washington Hospital has a much lower stroke mortality risk ratio. And this is our 30-day readmission rate. So comparing ourselves to other hospitals in Alameda County, Washington Hospital is the 6th lowest in their 30-day readmission rate. And that's really good when you consider our acuity and our high volume. And now I'll turn it back to you, Dr. Rose.
Thank you very much, Denise. So a little bit more about education. So we have a education booklet relative to stroke that we hand out to patients and their families. We do a lot of one-on-one nurse-focused education at the bedside to the patient and their families. We focus on rehab education as well. We have a full-time diabetes educator that can be called in for patients with diabetes that have stroke. The pharmacy team does a great job of helping do teaching about new medications especially, and making sure that they are going home on the proper medications. And we work hard to develop an individualized plan of care for every single patient. We also provide frequent staff education for all healthcare providers, doctors, nurses, other affiliated healthcare professionals. I present a monthly neurovascular case studies, or a stroke case study series. We actually just did that earlier this afternoon, where we go over interesting or especially challenging cases, and with the goal of working together and improving our outcomes, and to provide education about how to read complex scans and make complex, timely medical decisions. And we provide continuing education for not just the physicians but nurses for that educational series. Dr. Thomas and I also give a quarterly grand rounds on the topic of neurocritical care, and these are usually very well attended. They're here in Anderson, and we highlight our own cases and or some of our research related to subarachnoid hemorrhage patients especially, also, but other types of vascular surgical patients that may have AVMs, which are vascular malformations of the brain that can bleed, and we go over cases where we do advanced neurointerventional treatments for our stroke patients. And I also will sometimes discuss other neurocritical care issues that are not directly related to stroke but are relevant for our medical staff as well. And that is also available for continuing medical education for doctors and nurses. There's also stroke education modules that the nurses are encouraged and or made to review. We review our TPA and other stroke-related protocols on a frequent basis. There are monthly ED stroke education rounds. There are critical care education rounds, of which I typically will give one talk. And we have a new observation unit in 3 North that we recently launched, and we've educated the staff on stroke protocols there. Many of our stroke team members also attend international or national stroke conferences, such as the International Stroke Conference. One of our stroke nurses just got back from the Neurocritical Care Conference in sunny Hawaii. We also work very closely with EMS and are involved in the Stroke Alert Day. We submit data to EMS and participate in their quarterly meetings. For example, back in May of 2016, we passed out these FAST cards, which are it's a public educational tool to recognize stroke patients in a timely fashion. F standing for drooped face, arm, a weak arm, speech, abnormal speech, and time, recognizing it in a timely fashion and getting the patient 911 right to the hospital to get treatment. So this provides additional education opportunities for our program as well as for our EMS collaborators. In 2016, EMS alerted us to over 200 patients with stroke that were coming to our hospital, 225 to be exact. Of those 225, 55% of those patients ended up having a blocked artery stroke or acute ischemic stroke. 20% had a warning sign of a stroke, a TIA. 20% of them had an intracerebral hemorrhage, so bleeding stroke in the brain tissue, and 3% had a subarachnoid hemorrhage. We also, Denise presented some education to 40 new EMS providers earlier this year at a stroke update talk she gave back in April. We have a strong focus on community here that you've heard me say already. Not only do we focus on overall community education, but we focus on supporting our stroke survivors. And we have a stroke support group that meets monthly and that are led by one of our core stroke nurses. We provide education to these stroke survivors and or their families. We also do this to have the goal of improving social interaction, and we schedule social events, an annual trip, and to serve as a resource for the community. And it's not just the stroke nurses that are involved in this stroke support group, but we also have other guest speakers that come and give talks related to occupational therapy or palliative care, physical therapy, dietary issues, speech therapists, social workers, and sometimes pharmacy. We have other monthly stroke presentations to the community, and we've been seeing an increase in these in the attendance of these over the years, which is great. And thank you to our marketing department for helping advertise these and pull these off. We have an annual Stroke Awareness Day, and where we screen community members for free, their blood pressure, their heart rhythm, and whether they have a blockage of their carotid artery. And in the past few years, we've identified almost 50% of people with one risk factor for stroke that they may not have known about. And we also have our hospital-owned cable TV network that can provide education for the community. Beyond the community, we're also involved in a number of international and national organizations. I do also want to highlight our outgoing stroke program director, Dr. Ash Jain, who did an outstanding job of the program these past many years. And he's a member of the National Stroke-Related Organization, as am I and my co-medical director. We've had many achievements over the years, and these are just a highlight from a few in the last couple of years. We were awarded the Gold Plus Award from Get With the Guidelines, a 5-star Health Grades Award, Target Stroke Honor Roll, Elite Plus level, and we have a very comprehensive approach to stroke patients that help us achieve these awards. We're also involved in research and have made presentations about our work. Dr. Thomas and I just recently published an article in the neurosurgical literature in World Neurosurgery about our unique approach towards treating aneurysms that rupture, not only with endovascular small metal coils, but with clipping of the aneurysm after putting coils in, which was published a few months ago. And Dr. Jain has made some presentations in Paris, France. And we are newly becoming a site for a landmark carotid revascularization trial that, when it's published, will make front page of New York Times News, the CREST-2 study, which is a really crucial study looking at whether you should do a carotid surgery on a patient with an asymptomatic blockage of their carotid artery. And should you do that with a vascular surgery? Should you do that with a stent? Or should you only use medicines? So it's a really important study to participate in, and I'm proud that we're going to be a site for that. And I've already, this is the last slide, so Denise already showed you we have several performance improvement measures that we work very carefully on, and we have, we will find new ones in the future with a goal of meeting 100% compliance of all our key measures to make our stroke quality outstanding, and we will continue to focus on excellent patient care and community education and patient education, furthering stroke research at Washington, and in the future with our new facility, furthering our goal towards becoming not only a Joint Commission primary stroke certified center, but a comprehensive certified stroke center as well. Thank you very much for your time, and I hope this was informative and educational. Any questions?
Questions? Well, it's a tremendous presentation. I want to thank you, Dr. Rose and Nurse Lynch. Thank you very much. And thank you for your work. And beyond the presentation, it's just excellent work. And residents of our community should rest better tonight knowing that you guys are on the program. So thank you.
Thank you very much.
Okay, we are going to move on to the consideration of the minutes of the November 8th, 20th, and 27th meeting.
So moved.
Second?
Yeah, all those in favor? Oh, wait a minute. We got the new regimen here. New school, not old school. Okay, please take the roll.
Director Wallace,
Aye.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Danielson, Director Eapen.
Thank you. Are there any oral communications this evening?
No, there are not.
Oh, all right, thank you. Any, we're going to go on to written communications. Dr. Choi, thank you.
Good evening. I'd like to start with the new appointments. We have 7 people total. Janelle Bennett of Hematology, MD. We have Stephanie Carnes, a PA, a physician assistant. We have Gurpreet Jahal, internal medicine. We have Daniel Kennedy, MD, critical care intensivist. We have Pramod Krishnamurthy, MD, critical care intensivist. We have Tarun Kumar, family medicine, and Minal Mistry, PA, with Dr. Saw. Temporary privileges. The list includes Janelle Bennett, Stephanie Carnes, Minal Mistry, and Sarah Warman of MD for hyperbaric medicine. Under 2-year reappointments, we have Dr. Basil Besh of Orthopedics, Dr. Mandeep Chawla of Internal Medicine Hospitalists, Dr. Gail Dressler, Family Medicine, Dr. Joanne Falkenberg, Family Medicine, Dr. Afshin Goyumi, Family Medicine, Dr. Michael Golden, Physician of Medicine Rehab, James Hartford, MD, Orthopedics, Dr. Shashank Jolly, Cardiothoracic Surgery, PA Chelsea Joshi with Dr. Bruce Lin, Dr. Thomas Kelly, Teleradiology, Dr. Mark Koransky, General Surgery, Dr. Richard Lee, Internal Medicine, Dr. David Levin, Pathology, Dr. Surgeon Mahal, Family Medicine, D.O. Danny McCarthy, Teleradiology, Dr. Huey Fan, Pediatric Hospitalist, Dr. Nahid Rastami, Neonatology, Dr. Mark Saleh, Urology, and Dr. Lindsay Wazlewski of Pediatrics. 1-year reappointments can include Dr. Al Brooks, OBGYN Administrative, and Dr. John Dearborn of Orthopedics. Transfer in staff category include the following: Dr. Amardeep Angrula of Family Medicine from provisional to active, Dr. Rohit Arora, intensivist, provisional to active, Dr. Sambul Beg, endocrinology, provisional to active, Irene Bessner, OB hospitalist, provisional to active, Niti Dashi, pediatric hospitalist, provisional to active, Robin Goldman, pediatric hospitalist, provisional to active, Dr. Basil Curry, internal medicine, provisional to active, and Dr. Surjit Mahal, family medicine, active to ambulatory. We have Dr. Amy Mogul, intensivist, critical care, provisional to active, David Ornberg, emergency medicine, active to retired, Dr. Lindsay Wazlewski, pediatrics, active to ambulatory, and Dr. Frank Zaidan, emergency medicine, active to retired. In category of completion of proctoring advancement in staff category, All these members go from provisional to active, and include Drs. Angrula, Dr. Aurora, Dr. Begg, Dr. Besner, Dr. Doshi, Dr. Robin Goldman, Dr. Basil Curry, and Dr. Amy Mogul. Addition of a physician supervisor include the PA Anna Chun and PA Chelsea Joshi. Completion of proctoring prior to eligibility for advancement in staff category includes Cindy Liu, PA, with Dr. Sharma, Dr. Payal Shah of infectious disease, and Dr. Daniel Z of teleradiology. Extension of proctorship and provisional category, Shahzad Ahmad Chikabalapur, Shahzad Ahmad for intensivist critical care, and then Dr. Ajit Chikapalapur for internal medicine, Dr. Taylor Moran Gates, intensivist, Dr. Mona Sain, ophthalmology, Dr. Lois Vanderhagen, internal medicine, Christian Whittakin, perfusionist, and Helen Wong, hospitalist. New privilege requests include Dr. Mark Soleil for laparoscopic urology privileges major and minor, and Dr. Sarah Wharton for hyperbaric medicine. Deleting privilege requests include Dr. Dressler for assisted surgery. Resignations include the following: Abraham Ahmadi, family medicine, for non-payment of dues, Dr. Tamar Anwar, interventional radiology, Dr. John Arajo, PA, NP Igor Bedorov, Dr. Michael Harmon, radiation oncology, D.O. Christina Hobson, infectious disease, Dr. Bhavna Jain, internal medicine, Dr. Rishi Kapila, internal medicine, P.A. Nee Kok, physician assistant, Dr. Kong Mi Kim, pediatrics, Dr. Wendy Lee, internal medicine, Dr. Sylvia Militaris, infectious disease, Dr. Lily No, pediatrics, Dr. Gregory Perrone, teleradiology, Dr. Vikash Mishra, emergency medicine, Dr. Gunjan Sansina, internal medicine, Dr. Pervez Siddiqui, teleradiology, Dr. Gufran Syed, emergency medicine, Dr. Peter Tom, emergency medicine, Dr. Michael Tran, pediatric cardiology, Dr. Frederick Wilson, podiatry, and Dr. Romy Yoon, anesthesiology.
Is that it?
That's the end.
Man.
Tongue twister for me tonight.
That's the, they saved up a lot of work for you, didn't they? Thank you, Dr. Tsoi. Can I have a motion for approval of the credentialing action items?
Mr. President, I move for approval of the credentialing action items as presented by Dr. Choi.
Thank you. Second. Okay, we have a second, so then, Dee, please take the vote.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Danielson? Director Eapen?
All right. Debbie Jackson.
Hi.
Happy holidays.
Thank you. Happy holidays to you all, too.
Good to see you.
Service League has been quite busy this month. We had our holiday show in November, and it went really well. I want to thank everybody for coming out and supporting the gift shop, and thank Dr. Stewart for his kind words the other day today. For the gift shop, we've worked really hard to try to get it up and moving and full of lots of merchandise, and I continue to order. So thank you again. Raffle drawing for the trees went really well. Everybody was really happy, and it was a great joy to call all the recipients that got to win the prizes. They were very, very excited. And one was next door to us, and Victor, he just went crazy. He was so excited. He just jumped over right away. So it makes you feel good. It makes it worthwhile, and to bring that joy into somebody's heart, it's worth it. We had information and orientation sessions last month, and it went very well. I'd like to thank Dr. Nicholson, because we have a new adult volunteer in the gift shop, Grace, and she is delightful. Delightful. She is, I'm looking very forward to working more with Grace. And she came to our social today, and we're just embracing it and looking forward to having more adults come out and be part of our team within the hospital. So thank you, Dr. Nicholson. The other thing is Tree of Angels has been very busy. It was my great honor to be at the Tree of Angels for the Niles this year. And it's really amazing. I'm amazed how many people show up for the Tree of Angels. It's great in Niles. Beautiful weather, and just want to thank you. Then we went on to the Fremont for the mission at McDonald's. That was a beautiful ceremony, and the tree looked absolutely amazing there with the angels, as well as Washington West. I was able to attend that one. And the kids were just so cute, and seeing Santa and being able to talk. And the bell ringers from the Prince of Peace, they did a beautiful job. And I just so enjoy being a part of that. Unfortunately, I wasn't able to attend the other ones because I had other commitments. I hope everybody got their newsletters. We distributed that last month, and I hope everybody received one. And staffing for this past month, I'm just going to give you the overall. We had 2,479 hours of volunteer staffing this last month. Yeah. And we want to thank all our volunteers because we just can't do it without them. They mean so much to us and to the hospital and to the families and patients in the hospital. So,
Thank you.
any questions at all?
Any questions, anyone? Thank you, Debbie.
Okay, thank you. Appreciate it.
Sure. Okay, W.H.E.A, back to you.
So we have on staff at present 585 members, of which 333 are active, which is down a little bit.
Okay, thank you. All right, the hospital calendar.
Past health promotions and outreach events. During the month of November, Lucy Hernandez, Community Outreach Project Manager, presented 6 hand hygiene classes for students at Hirsch and Ardenwood Elementary Schools in Fremont. Information was provided on proper hand washing and hygiene to prevent infection and the spread of germs. 145 students attended. On Thursday, November 16th, Father Jeff Finley, Palliative Care Coordinator, presented Getting Through the Holidays When You Are Grieving. 26 people attended. Also on Thursday, November 16th, as part of the Women Empowering Women series, Dr. Victoria Leapart, gynecologist, presented Mindful Eating for the Holidays. 15 people attended. On Saturday, November 18th, Washington Hospital hosted the annual abdominal aortic aneurysm screening. Aneurysms develop over time and may have no symptoms, but if one bursts, it can cause immediate and life-threatening symptoms. Dr. Ashjane, cardiologist, Dr. Gabriel Herskew, vascular and endovascular surgeon, and Dr. Sarah Wortman, vascular surgeon, were on hand to interpret results from this Doppler screening. Of the 99 screened, 6 were found to have possible aortic aneurysms, and 15 were found to have other serious health conditions. A special thank you to Fremont Bank Foundation for co-sponsoring this screening. On Saturday, November 25th, Washington Hospital sponsored the 2nd annual Guy Emanuel Tip-Off Showcase at James Logan High School. The showcase offered health information and featured a high school basketball tournament with 20 teams from the Bay Area. The Team Spirit Award went to Heritage Boys Basketball for the most crowd to support their team. Kent Ashby from Deer Valley High School and Malachi Miller from El Cerrito High School won the Sportsmanship Awards. The awards were presented by Washington Hospital's Sports Medicine Program. More than 4,000 people attended. On Wednesday, November 29th, as part of the Speakers Bureau, Doug Van Houten, RN, presented stroke prevention to the residents and staff of the Masonic Homes of California in Union City. 30 people attended. Upcoming health promotions and community outreach events. On Thursday, January 18th, from 7 to 8:30 p.m., as part of the Women Empowering Women series, Dr. Victoria Leapart will present New Year, New You, Goal Setting. On Thursday, February 1st, from 6 to 8 p.m., as part of the Diabetes Matters series, Vida Reed, RN, will present Diabetes 101. The Washington Township Medical Foundation will host 2 community open house events at the Newark and Nakamura clinics on February 1st and 7th from 6 to 8 p.m. Community members will have an opportunity to meet the clinic's providers and staff. These free events will include a special presentation by Dr. Victoria Leapart on difficult conversations, tips on how to talk to your healthcare provider. On Thursday, February 8th, from 6:30 to 8 p.m., Washington Hospital will launch the 2018 Mental Health Education Series. Mental health is an area that merits increased education and information regarding available resources. This 8-part comprehensive series will feature expert speakers on various areas of mental health. Participants are not required to attend every class. Topics include Understanding Mood Disorders on February 8th. This seminar will provide an overview of mood disorders, including major depression, dysthymia, and bipolar disorder. Understanding Anxiety Disorders on February 22nd. This seminar will provide an overview of anxiety disorders, including panic disorders, generalized anxiety disorder, social anxiety, obsessive-compulsive disorder, OCD, and various types of post-traumatic stress disorder, PTSD. Crisis Intervention on March 8th. A crisis situation may occur at any time when loved ones are no longer safe to themselves or others. Through this presentation, learn to recognize the warning signs of crisis and understand what actions can be taken. Understanding Psychotic Disorders on March 22nd. This seminar will provide an overview of psychotic disorders, including schizophrenia, schizoaffective disorders, delusional disorders, and depression with psychotic features. The link between substance abuse and mental health disorders on April 5th. Learn more about how mental health disorders are common amongst a population suffering from substance abuse, including prescription and non-prescription drug addictions. When depression occurs with other medical conditions on April 19th. Depression can also arise in conjunction with other medical conditions or as a consequence of those conditions. Through this seminar, learn to recognize the signs of depression and when additional action should be taken. Mental Wellness on May 3rd. Learn strategies to develop the Wellness Recovery Action Plan and explore the benefits of complementary therapies for the treatment of depression and anxiety. Family Support, Caring for Those with Mental Health Disorders on May 17th. Family members can be an invaluable resource for individuals dealing with serious mental illness. However, caring for someone with mental health problems brings unique challenges. For more information or to register, please call 800-963-7070. The Washington Hospital Healthcare Foundation Report. For the 22nd year, Washington Hospital Healthcare Foundation welcomed the holiday season with the Trees of Angels celebrations. These tree lightings raise funds for hospice and palliative care in the Washington Township Healthcare District. The Trees of Angels celebrations were founded 22 years ago by Al Bernardin, the owner of several McDonald's restaurants in the Tri-City area. After witnessing the care given to a loved one by hospice nurses, Al decided to work with Washington Hospital to raise funds for families that did not have the means to pay for hospice care themselves. Al's son, Mark Bernardin, has continued the tradition, and each year the hospital and the Bernardin family light the angel tree together at McDonald's restaurant at the corner of I-680 and Mission Boulevard. In recent years, the Bernardin family and Trees of Angels have provided funds to help establish a palliative care program at Washington Hospital that focuses on relieving suffering for patients being treated for serious illnesses. The festivities began on Monday, November 27th, when Fremont Mayor Lily May lit the angel tree at the Bernardin family McDonald's. Approximately 75 district residents joined the foundation for the occasion and were treated to seasonal music sung by the Dickens Caroling Group. On Thursday, November 30th, the foundation hosted a tree lighting at Washington West, where past president of the foundation, Rod Silvera, emceed, and the Prince of Peace Christian School Handbell Choir entertained the crowd. The foundation partnered with the City of Newark on December 4th to light the municipal holiday tree at Newark City Hall. Helen Kennedy, president of the foundation, made remarks, and the Cougar Choraleers from Newark Memorial High School sang for the crowd. 4 nights later, on December 8th, the foundation joined with Union City and the Union City Chamber of Commerce to light a holiday tree at City Hall. Helen Kennedy emceed the event, and James Logan High School jazz singers set a festive mood for the event. 250 Union City residents watched as Mayor Carol Dutra-Vernacci threw the switch to light the tree at City Hall. The Northern California accounting and consulting firm of Frank Reimerman and Company, LLP, knows what the season of giving is all about. Their operations team recently created more than 200 care packages for patients receiving treatment at our Sandy Amos RN Infusion Center and UCSF Washington Hospital Cancer Center. The packages have tea, lozenges, a toothbrush, booties, stocking cap, toiletries, and hand wipes, and other useful care items. This was a wonderful gesture for our cancer patients, said Rochelle McCarthy, director of UCSF Washington Cancer Center. We thank everyone at the firm for their thoughtfulness. The Washington Township Healthcare District Board of Directors report. Washington Township Healthcare District Board members attended the Niles Festival of Lights Parade on November 24th, the Masonic Homes of California holiday tree lighting on December 7th, and the Newark Chamber of Commerce holiday luncheon also on December 7th. Washington Hospital Employee Association, W.H.E.A. The fires in the North Bay caused historic damage and forced the evacuation of thousands of residents. In response, W.H.E.A raised funds to assist families impacted in Napa, Sonoma, and Mendocino counties and other areas of Northern California. Janine Zayad, the president of W.H.E.A, said, "Our hearts go out to our friends and neighbors who have been impacted by the wildfires devastating the communities. We're committed to helping these communities as much as we can." To date, W.H.E.A raised $1,670. Washington on Wheels, WOW, Mobile Health Clinic. Washington on Wheels, WOW, Mobile Health Clinic is temporarily in Santa Rosa, California, helping support our North Bay neighbors who were devastated by October's wildfires. Santa Rosa Community Health serves 50,000 patients annually. The wildfires caused extensive fire, smoke, and water damage to its largest clinic, Vista Campus, and resulted in the loss of 56 patient exam rooms. The urgent need for temporary clinic space is the reason that WOW is in Santa Rosa. Our mobile health clinic provides 2 temporary exam rooms. Internet and social media marketing. Washington Hospital's website serves as a central source of information for the communities the district serves and beyond. The most viewed web pages include About WHHS, Employment, Programs and Services, and Physician Finder. The hospital's social media presence is measured through total reach and engagement stats. The total reach statistic represents the number of people who saw a Washington Hospital Facebook post. Social media posts may reach a user via a newsfeed, which is most common, a user's page timeline, or via a direct link to a hospital post. The engagement statistic represents users who liked, commented, shared, or clicked on a Washington Hospital Facebook post. InHealth, Channel 78. During the month of November, Washington Hospital's cable channel 78 InHealth captured new programming, including 3 health and wellness programs titled Nutrition Myths, Understanding HPV, What You Need to Know, and Getting Through the Holidays When You Are Grieving, and special presentations called Heart Health and Diabetes, What is the Connection, and Quick Meals on a Budget during the Diabetes Health Fair. In addition, InHealth aired a Diabetes Matters program titled Exercise is Medicine, a public service announcement on the importance of flu vaccination while you are pregnant, and the facility's master plan update, Phase 2. InHealth also aired the November Board of Directors meeting. For more information on any of the programs mentioned, visit WHHS.com or call 800-963-7070. And please follow us on Facebook, Twitter, Instagram, and YouTube.
I'd like to add a few things to that. We began that report with a picture of hand washing. We are entering the flu season, and this is probably the single most important thing besides your immunization that any member of our hospital community or the community at large can do to protect themselves. So we'll ask everybody to hand wash frequently. I'd like to report to the board that last week the Center for Medicare and Medicaid Services conducted a 4-day Joint Commission validation survey at the hospital. They had originally planned to be here 5, and they completed their survey in 4 days. And like the stroke survey and many of the other surveys that have taken place over the last 6 months at our hospital, this one was another great example of team effort on the part of our staff, both employees and members of the medical staff. We'll have to wait a couple of weeks for the formal written report, but the feedback that was provided by the surveyors makes me feel reasonably confident that any of the items that they identified have already been addressed while they were here or will be shortly. And the surveyors commented on our team's collegiality and commitment to patient care, which is high praise. While everyone throughout the hospital is excited to have another survey behind us, this survey was another great example of why we must stay focused on patient care, best practices, and be survey ready every day of the year. The stroke survey, like the CMS validation survey and the many other surveys that we've gone through this year, should make the board very proud of the men and women that work at our hospital who provide very good care, great care to our patients.
Thank you. You mentioned about the flu vaccine.
Yes.
But in the papers
Yes.
or on TV, you hear about the fact that the vaccine that's been distributed is not all that effective. Can you talk about that?
It is not effective for all the different kinds of flu that are circulating now. It is for many of them, but there are some exceptions. And it could mean a very big and serious flu season. There are people that are vulnerable, that have comorbidities, and they need to be very careful. That's one of the reasons why I think hand washing is such an important activity. Bill certainly could speak to this.
Well, trying to come up with a flu vaccine every year is a predictive endeavor by the vaccine producers, and sometimes they get it completely correct and sometimes they miss. It really underscores the most important thing about a flu vaccine is to get it year after year after year. Because when you've had the flu vaccine year after year, you're exposed to a number of different flu strains, and that improves your overall immunity to it. So just another endorsement of get your flu vaccine, get it every year. Don't be shy, just do it.
Yeah.
And don't wait, just get it done. There are plenty of places to do it, almost all the pharmacies, physicians' offices, clinics. Free vaccines are available in many venues, so it's really important just to get it every year. We've all had it.
Yeah, we have.
That's right.
We've all had it.
Yeah.
The other thing which is really important is just the standard precautions. Wash your hands. Cover your mouth with your sleeve rather than your hand. Try to avoid using, if you're in the family environment, you don't want to be using the same towels or other potentially contaminated things around the household. So just general cleanliness. But hand washing is clearly the most important thing.
Yeah. I'd like to present our Employee of the Month for December. Sharon Pulliam is a legal analyst in our compliance division. She's played a critical role in our compliance department since 2012. She assists with contract management, both vendors and physicians, claims management, subpoena requests, and hospital-numbered memorandums that document our policies and procedures. Because of her commitment to compliance with strict privacy and confidentiality laws at the federal, state, and local levels, and her ever-present enthusiasm to take on new challenges, she's a very valued member of the compliance team. According to her boss, our Chief of Compliance, Kristen Ferguson, she provides valuable support to both clinical and non-clinical departments, working well with everyone at all levels across the organization, and she always projects a warm, professional, and cheerful attitude. She was raised in Chicago. She's the eldest of 7 children. As her parents and siblings began migrating to California, she followed. It's fitting that she's our December Employee of the Month, as the holiday season played a role in her decision to become a legal analyst. Working in retail management for 22 years, she could not enjoy Christmas Day and certainly not Thanksgiving the way others did. With the 4 a.m. alarm looming ahead, I felt like my job with extensive hours on nights and weekends forced me to sacrifice time with my family. Seeking a career with meaning and a better work-life balance, she went back to school to become a paralegal. Working for several law firms, she learned many facets of civil law and honed her skills. In 2012, she accepted a contract role at Washington Hospital and was immediately impressed with our atmosphere, the patient-first ethic, and the dedication of her coworkers to work hard to fairly represent both the hospital and our patients makes coming to work a pleasure for her. Every day, she says, I walk through those doors with a smile on my face. She has raised 2 daughters and now enjoys the company of her 3 grandchildren and looks forward to spending lots of quality time with them this holiday season. And she's certainly an asset for our institution. We're very proud to have her here.
Thank you. Thank you very much. Okay, going to move on to the Lean Kaizen report.
Yes, we have 3 presenters tonight. You've met before Dr. Kirkjohn. She's been here since 2001. She did her undergraduate work at Stanford University and medical school at UC Irvine, went on to do her OBGYN residency at Kaiser in Oakland. She joined our medical foundation in 2011 from private practice, and she started in our Kaizen promotion office in 2016. Additionally, she serves on several medical staff committees. Also presenting tonight is Cheryl Bernal, received her undergraduate degree in nursing from Dominican University. She completed her graduate degrees with emphasis on business administration from Holy Names University in Oakland. She's been at Washington for 18 years, has held various roles in the organization, including staff nurse 2, staff nurse 3 and 4, charge nurse, and relief nursing supervisor. She's been involved in patient care services projects and research and magnet documentation preparation prior to transitioning to her current role as director in the Lean office. We also have presenting tonight Christopher Brown, and he is a graduate of the University of Oregon and has previously served in various roles as a healthcare communicator for more than 2 decades. Currently, he focuses his energy on the health system's Lean initiatives as a director with the hospital's Kaizen Lean Promotion Office. In that role, he oversees the supply chain, which includes central supply, the general storeroom, and purchasing, as well as the OR value streams. He's also the KPO's coach for our medical foundation, as the foundation is now integrating Lean into its daily operations. So those are the 3 individuals presenting tonight.
Thank you very much. So thank you for being invited back to speak to the board. It's always great to be here and tell a little bit more about what's happening with Lean. So as everybody's aware, next year some of the departments are going to be transitioning to the Morris Hyman Critical Care Pavilion. Really excited about this, and the Kaizen Promotion Office is just one of the several groups that have been asked to participate in this transition. And of course, we're really biased in the KPO. We feel like Lean has a lot to offer to help with that transition. So I want to tell you a little bit about what we're doing to help with some of that work. And we'll talk about the 3P design process, the current processes that are process improvements that have been going on in the emergency department, which are really setting up the ED for success in the move, and then our current 5S strategy. So we'll start with the 3P design process. So 3P is a little bit different from the the Kaizen work, which is the continuous improvement work. And 3P stands for Production, Preparation, Process. And it's really a lean tool, or a tool that we use when we have a new product or a new process or a new plant that we want to kind of design from the ground up. The methodology, again, it's a little bit different from the Kaizen methodology. Basically start by envisioning the product, design the product, select the best aspects of it, and then once you've selected those best aspects, then design the processes that help in that area. And then once you get your processes, then implement. Now, we were really fortunate in this process that the building has already been designed, so we didn't have to do that work. And a lot of thought went into the ICU and trying to incorporate things like natural light and some really amazing design features that will really improve our patient experience in the critical care setting. With 3P, one of the key things we encourage our team members to do is think like a 6-year-old. So we really want to get out of the business as usual, we have to do it this way in the new building because this is how we've always done it, and really try and engage that creativity and say, how do we really want it to be? If in the ideal world, what would that experience be like for our patients? And then design around that. So as I said, the building was already done, so we really have concentrated in 3P with the information and physical flows of the patients in that unit. So what have we done so far? Well, the first thing we did was a visioning session. And so brought the leaders together and really thought about what's the vision for the ICU. And Ms. Farber came and gave us some background about the design of the building and really helped us understand what the vision for that space is. And the purpose of that is actually so that when you start designing the processes that go in that building, you can really design around that vision of what you want your patient experience to be. And then we had our first 3P workshop where we looked at information flow and physical flow. So with information flow, one thing our teams did was actually created little stick figures of all of the people that are involved in the care of the patients in the ICU. The 3P, I forgot to mention, this 3P really is focusing on the ICU transition. And so by doing this, we actually were able to really see how many players are involved, how many staff people, clinicians, how big that care team is that takes care of these very sick patients in the ICU, and really helped us understand the need for good signaling between those staff members, need for very specific communication strategies so that all these people can have ways of signaling and talking to each other that's central to the patient. We also looked at the physical flow. So one of the things that's very different about the new building is that it's a much bigger space, more rooms. The rooms are more separate from each other, divided by walls and glass. And this really put some challenges for us. So, and the building is still under development, so we were able to go and see the building, but couldn't really work in there because it's still under construction. So what we did was we actually created a physical model of one of the pods in the ICU. And what this did was it really allowed us to we actually mapped out with string the flow of the patients and staff members through these spaces, and really helped us figure out what are going to be the challenges with the new workflows in this big space. How do we envision people moving from one place to another? How do we envision the movements of staff and family members taking care of the patients and visiting the patients? And that was all very insightful. So we have a few more workshops planned. We're going to be doing a workshop around care coordination, around the medication and pharmacy workflows, because of course those patients, a lot of medication issues or demands on with those patients, and then handoffs. How do we get patients into the ICU and how do we get them out of the ICU so that we make those smooth transitions to other parts of the building? So that's the 3P work. I'm going to turn it over to Cheryl, who'll talk about the current processes.
Jumping out of the small bowl into the big one. Very good.
Thank you, Dr. Kirkjohn. So as important as 3P and ICU in production, preparation, and process, it is also essential that a major unit such as emergency department to have participated in the previous Kaizen workshops to identify some improvement opportunities, and to also have processes that have been tested through PDCA cycle, that have been implemented and improved for efficiency and effectiveness of those workflow to make sure that they work for the staff and the workflow in the department. So some of these some of these process included during those workshops were signaling. Many of them are signaling, also patient handoff and standard work. So, which are significant because one of the biggest challenges in this new building is the enormous size of it. We're going to need signaling, we're going to need standard work, we're going to need streamline to make sure that our processes are streamlined. So some opportunities for improvement process in ED included, so these were worked on during the workshop, UA or urine analysis result to the physician, process for CAT scan of the abdomen, handoff report for inpatient floors, and rapid rooming in the fast track. Some of the root causes that were identified during the workshops also included lack of signaling or inconsistent workflow or lack of standard work. And some of the outcomes that impacted some of these workflows were physicians' disposition, decision, patient's length of stay, wait times, patient and staff satisfaction, and the capacity for ED to see more patients and take care of them. This is the track board that was developed during the workshop in collaboration with the EPIC team, the ED team, and the lab team to ensure that urine specimens is processed in a timely fashion so that the physician can order the most appropriate test. Another signaling that was created during the workshop, this was developed in collaboration with the EPIC team, imaging, and emergency department to ensure that the patient have the required IV access, that the patient is consented, and that there is a lab that is required prior to the CAT scan of the abdomen. So this signaling prevents any delays in the process. The next signaling is another signaling and communication device. In Fast Track is a dedicated track board to let the team know that the bed is clean and ready for patient to be rapidly roomed, and so that the physician can easily or readily see the patient. The next one is a tool, patient handoff tool that was created to ensure the patient information is streamlined, to have the right amount of information, to when you need the information, where you need the information, so that you can safely hand off a patient from emergency department to the floors safely. Multidisciplinary team worked on this tool to create this actually synchronized communication between the care team to ensure that there is a flawless process to move the patient from one floor to from ED to inpatient floors. So this process is currently in ED now. It was trialed in 4 West and has been now rolled out to different med-surg floors, and they're also rolled out in different shifts. Standard work for processes were developed during this workshop to reduce variabilities and inconsistencies in the processes. So standard work is referred to as an agreed upon set of procedures and that establishes the best and the most reliable method and sequences for each step of the process. By having standard work to do the process the same way each time, and also along with the signaling and the synchronized movement of the care team to provide a smooth flow and the transfer of the information that is streamlined, will help create a seamless transition to the new building, which is the Morris Hyman Pavilion. So as important as 3P and ICU and the current processes that we have now in emergency department, the workplace organization that we also called 5S is another crucial piece of the workflow. And so Chris will talk about that 5S.
All right, thank you, Cheryl. I'm going to be speaking to you about a very functional part of Lean, which is called 5S and focuses on workplace organization and is really one of the most fundamental and a foundational part of Lean. And I'm just going to quickly review here the 5 S's in Lean, which is sort, and that is where we clearly distinguish between needed items and unneeded items and eliminate those unneeded items. Set in order is the second S, and there we focus on keeping needed items in the correct place and to allow for easy and immediate retrieval. And the third is shine, and that's really about keeping the workplace clean. And the fourth 5S, or the fourth S, is standardize, and really that's a condition really meant to support the first 3 S's. And then the last S is sustain, which is making a habit out of doing all of the previous previous S's and establishing procedures. So why now? Why would we do this now before we're ever in the building? And I think it's really pretty simple. If you're moving, it's better to understand what's needed and not needed before you move, so that you're not taking stuff over to the new building that you really don't need. And you want to make sure that if you're taking items over there, that they're organized and labeled in a way that enables efficiency and less waste. And so up here in this picture here, that's on 4 West, and those, you can see that there's some bins there, there's color coding, a Kanban system, all of those different aspects to organization make it easier for staff to find things and know what's needed and unneeded there. We're going to be holding, for the ICU ED transition, we're going to be holding 4 transition 5S workshops that are scheduled from February through August. The first workshop is really going to focus on the current and future state. It's going to be looking at the current state of the ICU, and it's going to be focusing on the clean and soiled utility rooms, the medication room, a patient room, and a nursing station. And in particular, we're going to be looking at the sort and set in order S's of the 5S in that first workshop. And in workshops 2 and 3, we're looking at placement and flow. And we'll actually be starting to test things in the new building. So we'll focus on the medication and patient rooms, really doing an ideal state model in one pod that will then be rolled out to each pod by department staff. This is a really, what we're doing here is we're using a train-the-trainer approach so that we really empower the staff to expand this throughout the ICU and the ED. We'll be focusing on set and order, focusing on how supplies are placed and organized, and at that point we'll be setting appropriate par levels, and that's when the Kanban system will be established. In workshop 3, it will have the basically the same format, except the focus will be on the clean and soiled utility rooms. So in workshop 4, we'll be looking at the equipment and supply rooms, but really one of the most important parts of 5S is to sustain the gains that you make with the initial 5S. And how do we do that? We do that by using various tools. We use a 5S scorecard for the department, and we use a 5-minute 5S process so that the gains that have been made, for example, if the area is scored a 3 or a 4, probably a 3, a 4 is pretty hard to get to. But the 5-minute 5S actually is a process of going through a checklist either at the end of the day, or it could be at the end of each shift, so it might even happen 3 times during the day, going through a checklist to make sure that everything is back to where it should be so that you're able to maintain that workplace organization that you set when you did your original 5S work. So those are our plans for transitioning into the new building. We've got our hard hats and everything and are ready to be part of the construction process there, the moving in process. And at this point, if you have any questions, we'd be glad to take them.
Any questions?
I'm just impressed with your working at that already. That's great. Every time I've been in the building, in the new building, I'm just amazed at how big it is.
Yes. Yeah. Huge.
We're going to be hearing more as the months go by about our preparations to move into that building. And we'll be in that building for several months before a patient is cared for there.
Sure.
It is so dramatically different an environment. And we have to learn how to function there safely. And the idea that we're going to have to create signaling is very real. We have a critical care unit where patients are separated by curtains. We're going to a much larger unit where they're separated by walls. And you don't overhear a conversation or just be able to wave at somebody and get their attention. There's going to have to be a whole new system of communication.
Sure.
And it's something we have desperately wanted for many years, and we're grateful to be receiving it. But we're also going to have to develop new ways of doing business so that we can function in there safely.
Sure. Sure. Well, thank you, Chris. Thank you, everyone. Okay, so now we're going to hear from Ed.
Yes,
Okay.
construction report.
Okay, thank you, Mr. Walls. The construction schedule is still pretty much as you've seen the last several months. You can see that we're moving towards a early June date for us to do something that's called staff in stock, which means you get approval from W.H.E.A to start the move-in process. You don't have final completion, but you can see that that's slated in the early June period. And the late completion items are what's known as change order 134, which is the area in the back of the Hyman Pavilion that formerly had the helipad that we've talked about, and that's now being redesigned to cut that down in scope. And change order 67 is the back loading dock and connecting corridor. So you see 67 here is the majority of that work being done. We have to have that corridor in place to get to staff and stock. And this work down here is basically once the corridor's in, once the new loading dock's in, they go and work on the old section of the loading dock, bring some of that area up to make it match in terms of security issues, things like that. And then there's also a bioswale. So the drainage of water in that area goes off to a bioswale that will be located where There's currently space between the Center for Joint Replacement and the loading dock area, and it will be located there. Those are the late areas of completion in those two projects, those two portions of the projects. So, change order 67, speaking of, this is the change order 67 space. So, this is the work that's now started for the connecting corridor and the new loading docks. So, basically, we have underground utilities and we have structure underneath the buildings that are now being worked on and being put in place. This moves you to the other end of the project, and this is the front on Civic Center Drive, and you can see that there in the structure called the core bell, which is the concrete frame that the moat sits on. You can see a significant difference in the level of the land. So this whole area ground has to be brought up, and this has to be raised, and then we'll have here the ambulance parking, the loading and unloading part for the walk-in side, the handicap parking that's right in front of the ambulatory side. This all has to be brought up to level, and then we'll have paving and things like that going on there. So they've started that work as well. You're going to see on the interior, you're going to see more and more of a finished product. So this is the ground floor elevator lobby, and you can see the elevators there. And this is there will be both a patient side and a public side to this, and you will get to the MRI. This will be a direct shot to the MRI when that project is completed, under construction and then completed. This gives you another look at, you've seen several times, of the ER waiting area. You can see that getting closer to a finished product. This is the main lobby, so here's your atrium here. We'll see another picture of the atrium shortly, but you can see the rest of the lobby getting more and more of a finished look, and the terrazzo floor in this lobby is going to be started to be put in place shortly, and then through the months of January. This shows you a bay. This is where the lift tied into the building. So the lift has been removed. These walls are going to be closed in, so basically it's going to be fully, there's going to be no openings to the outside as this gets closed up. This shows you a respiratory therapy space up on the second floor around the critical care units. This shows you the outdoor space that we can move patients out into. You can see this is an area where there will be a bench. There's one also over here. And then you've got, it's hard to get the scale on this, but you have room out here for 2 beds, several people, several sitting areas. So that is one of the 2 areas on the terraces. This gives you a shot. You can see the nurses station getting closer to completion in the critical care. One of the 5 nurses stations in the critical care area. And here's a corridor on the 3rd floor. So you can see the atrium area still has a lot of work going on in there. Ultimately, there is floor-to-ceiling glass on the 2nd and 3rd floors around this, so it protects the inhabitants that are going to be on these floors. And here you can see the final metal sheathing is going on. It's now complete, with the exception of this area here, which is where the corridor gets tied into. All this is now done. So we're getting closer and closer with each month. And if there are any questions, I'd be glad to entertain. Okay.
Looks good, Ed.
Okay.
Yeah.
Thank you.
Okay, we're going to go to the quality report from Mary Bowron. Hi, Mary.
Good evening, thank you. I would like to spend some time tonight discussing some of the recent hospital rating systems that have been made public that relate to quality and patient safety. Over the last 10 years, this has become a bigger focus. There's a lot of different agencies out there reporting different metrics and looking at and publicizing different numbers. And I think for a consumer, it's hard to understand, what these ratings mean, what are they based on, things like that. So we thought it would be good to let the community have some background understanding on how these things are calculated and sort of some guidance on how to interpret them. Some background on this is that most of these rating systems have very diverse approaches to how they do this. That often can lead in each agency having contradictory results and their findings. And that's mostly related to the fact that some of them use different definitions, they use different criteria in their approach, different methodology, even different sources of data. Something as far as CMS is something as far as data that the hospital has provided and to them directly. It can range drastically. And as a result, there is actually, if you look at the real detailed research about comparing these systems, only 10% of hospitals rated as high performer by one rating system are also considered it by another. So a great deal of variation that we need to be aware of. And the next piece of it is that in California, there are even a greater amount of these that we need to be looking at. There are over a dozen of them. So what we've done here at Washington Hospital is just really try to stick to what are our fundamental beliefs. We want our transparency in our data. We want to identify our problems clearly and openly and be able to take interventions to improve those. And we have been able to stick to that by making sure that our data is valid and it's comprehensive and it's shared and it follows really some really national support systems and resources available. So the rating organizations that continue to be more in the media focus lately, there's some things to consider with them. Many of them you have to, you use the term pay to play. And that payment can be a little difficult to understand, but the key message is that many of these organizations do get a financial benefit to having you participate with them. And one of that may be something as simple as Leapfrog, for example. You can pay a licensing fee to then have your score advertised. There's different tools that these agencies can offer you per payment and or a subscription. Subscribe to us and then we're going to be able to advertise for you. These sort of things that need to be considered, that there may be some financial incentives in data and how it's public. Something to definitely keep into our consideration. Washington Hospital acknowledges that ratings are public. We see them throughout. We appreciate the fact that they're focusing on quality. We just would like to make sure that everybody has an understanding of what's valid and what's clear. So in getting to that, you can look at this long list of, this is about 19 different examples of quality rating systems. Very overwhelming to even me who worked in quality for a few years and has to look at these every day. I even still have a hard time, deciphering it. Can you imagine an average consumer trying to wade their way through this? So some of our ratings that are specific to our hospital recently have come out. And there's a couple, just to give you a couple examples, with consumer reports, we've been rated excellent with physician and nursing communications with patients. That's a big factor. Communication is probably one of the best ways you can get great quality in your hospital. Health Groove rated us on an 88 on a scale of 0 to 100, another great success. Then you look at a score like we have here with Leapfrog. We didn't participate fully in some of the things that they were requesting for the reasons that I mentioned before, because we can't participate in all of them, right? And so then sometimes your rating can be given differently because you're not participating. So something to take into consideration there. U.S. News ranked us the 5th hospital in SF metro area, and considering the hospitals that are around here and what great quality a lot of them offer, 5th is a great compliment to the organization. And specifically moving into awards. So there's rating systems, as I discussed, but then there are also awards that hospitals can get. One of the most common ones that consumers see are health grades. And health grades is a system that is based on star ratings. And they give us basically general surgery excellence awards, patient safety excellence awards, things like this that we've been able to receive are real achievements of success in our quality data that Health Grades has really looked at in a comprehensive manner over a long period of time, so it ends up being a much more trustworthy source of data. I think everybody in here is familiar with Joint Commission. We've heard a lot about it. Joint Commission was at our hospital this year twice. As you heard earlier tonight, the great outcome we had was stroke. We also had a great outcome with our overall hospital Joint Commission survey. Highly credible source to look at for how hospitals are judged and determined on their quality in the facilities and services that they offer patients. It's key. It's federal, even in parts of international in the world. So Joint Commission should be taken very seriously, and we've had some good successes there. Moving on to data reporting at Washington Hospital, a huge focus on what we do in quality is looking at databases and how do we report to them. Some of them are mandatory, some of them are voluntary, some of them we participate in so we can learn. One of them is our cardiovascular databases. We looked at all of our cardiovascular surgeries that we perform here, all cardiac casts, things like that we participate in on a voluntary basis because we want to know what's the outcome of the data that we are having with our patients who are receiving those services. Those are a couple examples. We report on everything from a county level for our Alameda County Public Health Department. We report things to them daily, all the way up to federal CDC participation. Very comprehensive set of data reporting that we've done here at Washington Hospital. Again, not all required. We participate in many so that we can know where should we make our improvements and have data that we can look at in a meaningful manner. Centers for Medicare and Medicaid Services, they provide a star rating system. And this is otherwise known as CMS, of course. One of the biggest organizations on a federal level that is looking at your quality that we send them based on claims data, based on data that we report to them. And they rate it on a 1 to 5 star scale, which is much easier for a consumer, I think, to understand. And basically, that gives the consumer the ability to make informed decisions on where they may choose to have their care. One of the things I like about the CMS, our star rating system, is they take the data very seriously. It's comprehensive. There's a lot of data that we send them, and they validate the data. This year, for example, we were validated. They come in, they say, I want 3 samples of the charts on how you did with core measure abstraction, things like this. And then they report back to you. They go to really great deal of effort to validate your data. This is a very credible source. In our last 2 validations, we've received over 90% match rate for what they were looking for. And so they feel like our data is very valid for what they're receiving. And actually, we have moved. The latest published data is that we had a 3 out of 5 star rating. We just actually moved up to a 4 out of 5 star rating as I received that notice last week, and that will be made public on Hospital Compare. Very reputable source, very comprehensive, requires a lot of data to be submitted, but it helps us understand, where are any issues that we would have around readmissions, patient experience. There is another thing they determine when they give you that score, timeliness of care, even right up to medical imaging, all these things. So a 4 out of 5 is a good score from a comprehensive source. Health Grades is another one that they focus on your general hospital quality over time, and they also publish your awards for excellence in patient safety and experience for your top 10% of facilities. And they also give awards to hospitals that perform well over consecutive years. Another good source is Health Grades because they're looking at a high volume over a large period of time. So something the consumer should consider a reputable source for sure. U.S. News and World Reporting, another popular one that you'll hear about a lot in the media. They have provided hospital ratings for about 30 years. They have a great deal of experience in this. Their quality metrics tend to be objective and change to match the evidence that changes over time with what they want to be looking at. And they also look very closely at Medicare data, which is one of the most popular sources of data that you can find out there right now to look at and measure quality on. And they rank our scores differently according to metrics that I had just mentioned, similar to health grades. Readmission, survival rates, things like that are what U.S. News and World Reporting ranking is looking at. Leapfrog group, I've mentioned them a little bit before. I want to keep in mind that this is a voluntary group that you can participate in. If you, and like I said, we've participated in the bigger, more comprehensive ones that I mentioned before. Leapfrog is not something we voluntarily participate in, so they don't have access to really all of our quality data. They go to a secondary source with Medicare, they get this data, which then makes it to be in periods of time that are sort of, could even be as far back as 2 years. And if they don't have access to all of it, then you don't get as comprehensive of a report. So that's one that, we take a little bit more into consideration with, it's one that you should probably think much more closely about when you look at that score. 80% of hospitals receive a C or less grade because of this, because there can be little areas that are missed in it because, again, unless you're volunteering, they're not going to get the comprehensive scene on your quality, right? Not to the same extent that CMS or Joint Commission or much more bigger reputable sources would see. So we recognize that we need to have a strategic approach to how to review these ratings. They're out there. Many of them are public. Again, confusing, need to be reviewed currently on a basis that we want to be looking at them anytime they're published, reviewing them so that we understand what is in this score, where did they come from this, what's the time period they used to look at it. These sort of things need to be considered. So for us, factors that we're considering is how current is the data. So for example, if you're reading a report from Leapfrog or something, and you say, oh, they have a problem with multiple drug resistance there. First question is, when did it happen? Are they reporting something from 2013? And here we are in 2017, made significant strides and improvements in those. And that is something that is not even being made public because the data is older. So, and is it validated? That's a key question in this. As I mentioned before, CMS validates our data. And so those scores can be considered very accurate because of that. So it gets away from the subjectivity, basically. How transparent is the methodology? Methodology meaning, how did they calculate this data? Where did they come up with this number? Is it biased? Were certain cases excluded? Were they not? Are the definitions standard definitions that CMS or Joint Commission would use? Or are they something this agency is looking at in a much more different light? So things to consider also with that. I already mentioned the time frames and how important it is to look at that. Does the rating system look at actual clinical outcomes? So how did the patient do when they left? And what were their outcomes? And did they return to the hospital? These sort of things you really have to be able to consider when you're looking at that. And again, a very important part to remember is the hospital required to pay to have these made published or marketed in a different way? Of course, changes some of those results. So our future direction on focusing on this is we recognize there are many sources for this. We have a responsibility in quality to keep the community informed on, what's reputable, what may not be, and help them understand the differences in the sources. So we'll continue to focus on that. And that's really driven by the patient-first ethic. All data that comes through Washington Hospital and is looked at in the databases and the sources is looked at in a manner of what can we do with this data to make it meaningful? What can we do to improve the patient experience here? What can we do to improve their outcomes? That's what our focus is going to be. That's always been the mission. That's what we continue to want to do moving forward with our data. In spite of what 10 or 12 other agencies may have different interpretations, we want to continue to focus on what we're going to do based on the patient-first ethic to improve our care here with that data. We also want to make sure that we're reporting to all required necessary organizations. As I mentioned before, CMS, Joint Commission, really the backbone of where data goes and where we can trust some of those outcome sources. A lot of that will be involved in looking at patient safety and making sure that whatever quality data that we bring and patient safety, that the board and the community hears about it every month. That's key. It's been a focus here. That's not something you'll see around in a lot of facilities. And so we've really tried to keep transparency here so that we can keep everybody informed and let them know that we're doing with the changes and what we're seeing with our data. And then, of course, the ultimate goal, and one of the parts that most hospitals struggle with is, how can we sustain it? So we've seen some recent decline in C. diff, for example, that we're hoping to see even further decline the rest of this month. And I was meeting with Dr. Martin, our ID physician, today, and she said, okay, so now we're moving on to how can we sustain that? We're making some real achievements there. The data is coming down, again, based on a source like CDC, federally definitions that are provided to us, and a great source of data for it. But what can you do to sustain? And then as you identify quality problems, what new initiatives would we be starting based on the quality that we're looking at reputable sources? As there are, that's our goal with sort of handling this big source of data.
Wow, thank you, Mary. Any questions?
Yeah, Mary, I have a question. In your opinion, what would be the top 3 or 4 rating entities which rely on validated current data? What should a consumer, if they're going to pick just a handful of agencies or entities to look at, which entities are in that top tier?
Yeah, I think that's a great question. The first thing that I would look at is Hospital Compare, because it is it's very easy for
That's
a
CMS,
consumer,
correct?
which is based on CMS data. Exactly.
Okay.
So it's called Hospital Compare based on CMS data. What I would encourage people to do is really pay attention to the time frames, because they report sometimes a little bit after, but it's a great source, and that's validated. As I mentioned with our example with our 90% compliance rate with that, I would go to CMS. Joint Commission is a friendly website. Their data is not as publicly made on there because they just rely on the CMS one. Another one for people living in California is California Department of Public Health has a website, fairly easy to get through, that will give you and list all hospitals and where they rank, especially with healthcare associated infections. Very easy to understand. Red star, yellow star, a green star. CDPH website's great, and you can compare the hospitals around you. They validate. We're not required to have them validate. For the last 2.5 years, though, we have invited and volunteered to have them come in and validate our data. So I feel very strong in the data that's publicized there. Those would probably be the best resources to go to. They also have things on there that will help people with language barriers, so you can kind of look at alternate sources of getting it translated into different forms of language, and they'll call, and you can call and they'll help with that.
Great, thank you very much, Mary.
I might be cynical about this, and I apologize for that, but it seems to me CMS, that's the governmental agency that they are paying us for the services that we provide, and they are providing grades, and they're paying us. Organizations like Leapfrog expect us to pay them, and so and you don't. So I'd rather trust the folks who are paying us than folks who expect us to pay them.
Absolutely.
In terms of how we are scored, because I don't believe that we'd be getting the payments we're getting if our grades weren't significantly better than most. So,
and the CMS data is far more complete.
Yeah.
When you look at the list of 19 or so or more companies that do this, I made the decision that we weren't going to pay everybody to rate us.
Correct.
We can't afford it.
Yeah.
And the amount of time and energy it takes to submit all that data to everybody and all their different ways of receiving it could cost us a fortune.
Sure.
And there is enormous inconsistency from one rating company to another, and some of them, like Leapfrog, mix up years.
Sure.
They'll take 2013 data for one thing and 2015 data for another, and they won't tell you that they've done that.
Yeah.
And the rules of biostatistics are very clear. You have to compare like things and like years and like groups of information, and they seem to go off-road when it comes to that.
Yeah, it's a shame. Yeah.
It is a shame because it creates impressions in people's minds without disclosing how they got there.
Yeah.
And so there are hospitals now that are suing Leapfrog. There's one in West Virginia. There's another one in Chicago. And I'm sorry, I'm not paying them
Sure.
to do this.
No.
We just can't pay everybody.
No, that would.
But
no,
after a while, you
that's
begin to
form-
feel like you've been, this is a stick-up.
Yeah, it is. Yeah. Well, thank you, Mary. Thank you for explaining this. I know it's very confusing to
It is,
people.
even for me.
It
Yeah,
was
so
a
thank you.
very good presentation. Thank you.
Oh, thank you.
Thank you. Okay, Chris Henry, the finance report.
Evening. Tonight we'll be looking at Washington Hospital's operating and financial results for October 2017. Operating indicators, average daily census for October came in higher than budget at 154.1. We'd expected 150.8. We had 1,035 admissions against a budget of 926. And our patient days were 4,777, about 103 above the budget. Outpatient observation equivalent days were 57 below budget at 141, and our average length of stay for the month came in at 4.68. We'd expected about 5 days. Moving into utilization, case mix index for the month lower than we'd expected at 1.451. We're really looking for a little over 1.5 this year, but we'll see how it all develops. Our deliveries for the month came in at 140. We'd expected 145 in the budget. Surgical cases were 30 below the budget at 337. That includes our joint replacement cases that were 4 above budget at 132. Neurosurgical cases were above budget by 4. Our cardiac surgical cases came in 5 below budget at 14, and then the balance of that came through general surgery. And really, we're seeing the budget deficits coming in on the outpatient surgery side. So we're just not seeing the outpatient cases this year that we had expected and had seen for a long time. Cath lab procedures for the month were 25 below budget at 313. Our outpatient visits actually came in 759 above the budget at 7,741. And our emergency room came in pretty close to budget at 4,362 visits. Quick look at our cath lab activity for the month. This month, cardiac wins at 42% of the total activity. Peripheral vascular came in at 39%, and those are kind of trading off. Both of those pieces of business are holding in strong, followed by our non-vascular IR at 18%, and then neurointerventional radiology rounding that out. Looking at productivity, our productive FTEs for the month were 19 above the budget at 1,250.9. We had 160.1 non-productive FTEs in October, giving us total FTEs that were 15.9 above the budget at 1,411. Our FTEs per adjusted occupied bed, however, that's our productivity measure, came in pretty close to budget at 6.76. So, the FTEs were appropriate for the levels of activity. Moving into the financials, total patient revenue for the month came in a little over $2.9 million below the budget at $162,620,000. Contractuals for the month came in pretty favorable at 75.13%. Really doing a good job of collections right now, and our collections seem to be getting stronger in the PPO bucket. And I think a lot of that has to do with Epic and the information that our collectors get and our patient accounting folks get in their work list. It really focuses them on what to work. And I think part of that is coming through in these contractuals that we're seeing this year. We did have some collections. We had a collection on the 2006 cost report reopening. We had received a settlement of a little over $250,000, and then Triage, who works our closed accounts, had some pretty good collections in the month. So really a good month from a contractual standpoint. So we ended up the month with net operating revenue almost $1.7 million above the budget at $40,918,000. Operating expenses for the month came in $1,380,000 over budget. Almost $1 million of that came from our health and welfare claims this month. We are really seeing high health and welfare claims this year. At the end of October last year, we were running $2 million less than what we're running this year. Another indicator is when we hit our stop loss level. So we have reinsurance on our self-insured plan, and that stop loss kicks in at a certain level. Last year, we didn't hit our stop loss level to where we could start collecting on that insurance until May. We already hit it in October this year. So we're really seeing high claims. And that's just the way claims go sometimes. You know, you get a couple of really sick folks and it can really drive those claims up. So we'll keep an eye on that. Don't know if that'll continue through the year. We'll see. Other things driving that variance, our salaries and wages were a couple $100,000 over budget with our higher FTEs. Also have in purchase service area, we still have a dialysis contractor working here as we work to get the equipment in and get all that together so we can bring it in-house. We expected to have that done in August or September, and we're just running a little behind. So hopefully we'll have that done shortly. So we end the month of October with an operating bottom line about $318,000 above the budget at $1,152,000. Non-operating income for the month came in $322,000 below the budget at $1,446,000. We did have a $236,000 unrealized loss in our investments for the month, driving the majority of that. So we ended October, and again, this is from the GASB point of view, the Governmental Accounting Standards point of view, pretty darn close to budget with the total bottom line at $2,598,000. Run really quickly through the Financial Accounting Standards Board format. This is the way the financial markets might adjust our GASB financials to take a look at us. Operating bottom line stays the same at $1,152,000. We pull out our tax revenues that support the debt service on our general obligation bonds and that unrealized loss on our investments to adjust non-operating income to $326,000, about $87,000 below what we expected in the budget, and a total bottom line from a FASB perspective about $231,000 above the budget at $1,478,000. So are there any questions on October's results? Nope. Okay.
Thank you, Chris.
Ready for the preliminaries for November? Sure. Our gross revenue was $166.3 million for November and was above budget by $1.1 million and above November a year ago by $7.7 million. Our inpatient gross revenue was $7.4 million above budget, and it amounted to $127.4 million. Our outpatient gross revenue was $6.3 million below budget at $38.9 million. The major drivers of revenue variance were surgical volume, which came in below budget by 4%, driving our surgical services revenue down by $284,000 below budget. Our cath lab procedures were also below budget by 26, and so our cath lab revenue was below budget by $322,000. Observation days were below budget by 41.1%, driving room and board revenue below budget by $391,000. Although our total inpatient days were below budget by 15 days, our ICU days were above budget by 9.5%, or 52 days, driving ancillary services revenue above budget by $2.4 million. In terms of our key census statistics, our average length of stay was 4.37, and that was below the budget of 4.98. The average length of stay was 0.21 days, or 4.6% below November a year ago. Our outpatient observation days were 85, below budget at 122 days. The outpatient observation days were 110, and that was below November a year ago. Our average daily census of 157.8 was very close to the budget. Budget called for 158.3. The average daily census was 8.6% higher than November a year ago. In terms of our admission trends, our admissions of 1,022 were above budget by 68 admissions. They were 72 higher than November a year ago. In terms of our patient days, 4,735, they came in below budget by just 15 days. Our patient days for the month were 377 higher than November a year ago. The surgical trends in November, we came in 362 below budget. They came in at 362 and were below budget by 15 cases. Surgical cases were 41 below November a year ago. Our inpatient surgeries were 31 above budget. They came in at 296 in total. And the outpatient surgeries were 46 cases below budget. General surgical cases were below budget by 33. Neurosurgical cases also were below budget, but only by 2. Cardiac surgery cases came in above budget by 1. Joint replacement surgeries were above budget by 19. The cath lab procedures for November numbered 285, and they were 26 cases below budget, but 11 above budget a year ago. Inpatient cath lab procedures of 139 were below budget by 8 cases. Outpatient cath lab procedures were below budget by 18 cases. Cardiac procedures in the cath lab were below budget by 2, below last year's volume by 5 cases. Non-vascular interventional radiology procedures were below budget by 4 cases. Neurointerventional radiology procedures were below budget by 5, and peripheral vascular procedures came in below budget by 15. Our deliveries for November were 148 in number, and they were below budget by 2 deliveries. They were 3 deliveries more than a year ago, the same month. Our non-emergency outpatient visits of 7,228 were above budget by 178 visits, and they were above November a year ago by 378 visits. Our cardiac rehab visits were above budget by 156. Clinical lab visits were above budget by 143. The infusion center visits were above budget by 56. Our short stay visits were 122 below budget at 164. The prenatal diagnostic center visits were 40 visits below budget at 118. And again, that is being artificially constricted by the state still not giving us the license for the space. And apparently on the last inquiry, they had misplaced documents we had previously sent them. This is getting to be a statewide issue. We're not the only hospital being subjected to this, and there are apparently a raft of complaints about the inaction. It gives me some concern about what they're going to do when they have a whole building to license as opposed to one clinic. And, you know, we have our timetables for the Morris Hyman Critical Care Pavilion, and I'm wondering what's going to happen. And we've had inspectors on site from the inception of this project, and I'm hoping that makes the difference. And we'll see, but it is an unknown. The emergency department saw visits of 4,031, and they were 241 visits below budget and below the same period last year by 181. Our productivity indicators for FTEs came in above budget by 36.1. Now, there are a couple of things that are factored into this. One of them is the unannounced validation survey, which certainly brings more FTEs into the building to handle 10 inspectors who arrived unannounced. We also had some mandatory in-services as it relates to medication that occurred on all 3 shifts for 100% of the nursing staff. And that also adds to it. So about half of this comes from there. Our non-productive FTEs came in below budget by 1.5. So our total FTEs of 1,453 were above budget by 34.6, or a 2.4% variance. Total FTEs per adjusted occupied bed of 7.05 are above budget by 0.54. Other operational statistics. Our outpatient surgery center had 510 cases in November, and this was 53 cases above the budget. So you can see where general surgery is going with the outpatient cases. They're across the street, not here. Clinic visits of 3,550 were below budget by 296 for the month of November, and 222 below November a year ago. Washington Urgent Care was down by 136 cases. The Nakamura Clinic was up by 17. Newark down by 142, Warm Springs below budget by 15, and the Ohlone Clinic down by 20. Our preliminary payer mix for the month of November is government-sponsored patients, making up 71% of our total gross revenue, which came in slightly below the budget of 71.8. HMO revenue was 2.7% of gross revenue, which is below the budget, which was 3%. The PPO revenue was 23.9% of gross revenue, which is above budget, which called for 23.4. Private pay revenue was 2.4% of gross revenue compared to a budget of 1.8%. And I think that is worthy of note, in that more uninsured are beginning to arrive on our doorsteps as brick by brick the Affordable Care Act seems to be in a state of being dismantled. And I think that we're going to see those numbers rise. They've been significantly lower for the past couple of years, and I think that we're going to see a steady rise back up to levels that preceded the passage of the Affordable Care Act. In terms of our key financial statistics, days cash on hand for November ended at 191 days, up 5 days from the prior month. Days of gross revenue and accounts receivable were 53. I don't think I've ever seen it that low. There were $631,069 in charity care applications pending or approved in November, and that's more than double what it's been in prior months, and you can just begin to see it mount up.
Thank you. Any questions? All right, we're going to move on to the action items. Can you take on?
Yes, I'll be happy to present item A, Mr. President.
Thank you.
I hereby move for acceptance of the audit report for fiscal year ending June 30th, 2017, as presented at the October 11th, 2017 Board of Directors meeting, and that the Secretary be directed to publish the report in accordance with applicable law and hospital policies and procedures.
Second.
Thank you. Any commentary?
No, the audit was presented here to the board previously, and this is a necessary action the board has to take.
Yes. Okay, Dee.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Eben? Director Danielson?
Okay, thank you. Director Nicholson.
Item B is omitted. We're going to go to item C. Mr. President, in accordance with district law, policies, and procedures, I move that the board authorize the chief executive officer to proceed with the purchase of hardware, software, and implementation services in an amount not to exceed $1,174,393.
Second.
Okay.
This is the necessary new phone system. The one that we have now is over 10 years old, and it doesn't have the features and integration options that the new solution provides. It is, I think, important for us to install the new phone system in the hospital now, so that in addition to learning a new physical space, our staff doesn't have to learn a new phone system as well. And so I've asked that this appear now, and we have the new phone system installed in the existing facility, so everybody's familiar with it before we open the doors at Morris Hyman.
Thank you. Dee, please.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Danielson? Director Eaton?
Okay, seeing there's no other actions, we are now going to adjourn to a closed session. Thank you. We're going to reconvene the open session and announce that during the closed session, no reportable actions were taken. With that, with no further business, I wish you all a very happy holiday season, and the meeting is adjourned.